Today I'm going to be covering airway management techniques, and that starts with an assessment, appropriate preparation, and then we're going to be looking specifically at the techniques of bag mask ventilation, intubation, the use of a bougie, and the use of a supraglottic airway device. Now, assessment of the airway is an absolutely critical step that must happen in every patient that comes to theatre. Preparation and thinking through what will happen if you don't get your initial intubation correct, or whatever your initial plan A is. What will you do if that doesn't work? Positioning the patient appropriately, oxygenating before you start, and then appropriate technique. And these steps should occur in every patient that you do a general anesthetic for, but you should actually think through them even in the patients that you do regional techniques on. Now, you must assess every airway that comes to theatre, not just the general anesthesias. And that involves looking at the indication for the anesthetic and the airway plan. Now, the indication for the anesthetic might make the airway a difficult airway. They're not only about anatomy, but also about physiology. So there might be a need for speed or for a particularly gentle intubation, there may be a hemodynamic instability. So the patient condition is very important because you're about to give them serious drugs, and being rushed doesn't help your frame of mind or your success. So when you think this is a difficult airway for whatever reason, whether it's anatomically difficult or whether it's physiologically difficult, get senior people in the room, get at least 2 pairs of hands. When you assess an airway, you must assess at least 3 areas every single time. We're not going to cover the difficult airway today, but you should get into a habit of doing these 3 different assessments every time you do an airway. And the first is mask ventilation. Am I going to be able to do mask ventilation? And we use an acronym called BONES. Am I going to be able to do laryngoscopy successfully? And we use an acronym called LEMON. And will I be able to do a rescue airway, a surgical airway, if I get into trouble? And there is an acronym for that, but I'm not going to cover that today because you mostly just do that by assessing the anatomy. So the mask ventilation acronym is BONES. And if you get any positives here, it means that you might have difficulty with mask ventilation, so get a senior in the room or get that second pair of hands. The B stands for beard. Does the patient have one? The O for obese, and obese is only a BMI of more than 26, which is actually just mildly overweight. No teeth. Elderly, and again, elderly is just for patients over 55, so not exactly ancient, but older than 55, and then a history of snoring. Any of those factors are present, and you have risk factors for mask ventilation. Do this in every single patient that you anesthetize. Then you need to assess laryngoscopy, and again, we use an acronym called LEMON in this one. L is just look at the airway. E is for evaluate. Now, if you go and look it up in the ASA guidelines, there are 11 different criteria that you must look at. But even if you're just taking the step of looking and evaluating, that is a win. The Mallampati score should be done in everyone. And just to remind you what that looks like, this is the Mallampati score that is sitting with the mouth open. Mallampati 1 or 2, where you can see all of the uvula or some of it. Those are associated with a more simple or an easier laryngoscopy. Watch out for that class 3 or class 4, where you can only see the soft palate and the base of the uvula, or only the hard palate. Those are the ones that will be difficult to intubate. So that's the Mallampati, and then you must look for obstructions and neck mobility. So those are good things to look at when you're assessing laryngoscopy. I always add not only the Mallampati score, but I also look at the thyromental distance. It's hugely important. So if the distance from the chin to the thyroid cartilage is more than 6.5 centimeters, that's associated with easier intubation. But actually what I'm doing is I'm looking for that short one, less than 6 centimeters, which tells you that there's not much of a gap, and therefore the larynx is going to be high. It's going to be an anterior larynx. And an anterior larynx means that it's very, very difficult to get the tube around the corner or visualize the appropriate anatomy. So get used to looking at the thyromental distance. The airway trolley, you must know how to set this up. You need a working laryngoscope, ideally 2, different size blades, different size endotracheal tubes, Guedel airways. You need a supraglottic airway device like an LMA or a ProSeal or an iGel, at least a size 3. On the cart, you need a McGill's forceps. So go there, and it's the 5 plastics and the 5 metals. Check it every time. But what I want to actually stress with this slide is that the preparation must be patient appropriate. So you don't just check the airway trolley and that's done for the day. You must think about the patient that you're doing. What size supraglottic airway device would I want in that patient? And that's what should be on the trolley. So you don't have to think about the sizing when you're in an emergency and you're reaching for it. You've already done that thinking before you got into trouble. And it's a key part of checking your equipment. The next thing is you want to position the patient correctly. And what you're trying to do is obtain a straight view to the larynx when you eventually intubate. And there's 3 axes in the airway. There's the oral, the pharyngeal, and the laryngeal axes. And as this illustration shows, when the patient opens the mouth wide and lifts the, you're not going to be able to see when you stick the laryngoscope in at that angle, because you're trying to see around the corner. If you then get the head above the bed and tilt the head backward in this position, then when you look with the laryngoscope, you're seeing at a better angle. And you can also use this way of getting the head forward. Look at where that mastoid process is. It's come right forward to be in line with the sternum. So I position patients and then I walk around laterally on the bed and I see how that head has come forward. And notice also the thyromental distance now looks much longer. It's a good way of testing if you've got the positioning right. So get this positioning right. Spend time doing this before you attempt an airway. You can also use that method. So some of these now are just the essential airway management techniques that I wanted to go through. The first is mask ventilation, and this is a vastly underrated and often poorly taught skill. Remember that we're aiming to ventilate the patient. The goal is not intubation. That may facilitate ventilation. The goal is to ventilate the patient. And if you can't intubate or insert a supraglottic airway device, this technique can get you through a general anesthetic. So it's really important. Now, this is the grip that you find is most commonly taught. So looking from the side, you've got the mask between your thumb and your index finger, and the other 3 fingers are underneath the jaw. And remember that you're not pushing the mask down, you're lifting the jaw up. That jaw has got to come up. And the little finger in this technique is hooked around the angle of the jaw, and that's what you're actually using to try and lift the jaw up. Now, I find that quite difficult, either if it's a difficult jaw to lift, or in people that I'm teaching that have small hands or aren't used to doing this or not strong enough. This technique is actually very difficult to get the jaw up. So it's useful when it's an easy bag mask ventilation because it frees up a hand, but it doesn't work very well when you've got a difficult mask ventilation. So then you can consider using 2 hands when you're struggling. Now, difficult mask ventilation by definition needs 2 operators. So the one operator is squeezing the bag and the other one has got that jaw and is lifting that jaw up. And again, this technique that's shown here is not very effective for lifting that jaw. You can see now we're slightly more effective. Those little fingers are underneath the angle of the jaw. And you'll find in most patients you can get the jaw up in this technique. It's still not my favorite. What I prefer to do is to actually reverse my hands in a difficult mask ventilation. So put the thumb on the mask and get all 4 of those fingers behind the angle of the jaw and lift up. You must feel the jaw come up. And you'll find that this is what works when you've got a really difficult mask ventilation. Often you add a Guedel airway as well. And then this technique, it's easy to do. You can feel the jaw lift up. And your hands don't get tired, so you can do it for a while, and then someone else is doing the mask ventilation. So if you want to see a video of somebody doing that, this is what it looks like. You can see he's getting his hands underneath the angle of the jaw and just using his thinner eminences or his thumbs to hold that mask down, and now I can really lift that jaw up. And if that's not working, I get all 4 of my fingers underneath the angle of the jaw. But this technique is a very useful one for doing difficult mask ventilation. And if you're interested in seeing the full video there, go to ABCs of anesthetics, and they've got lots of nice videos on these different techniques. So now we come to laryngoscopy, and this is contained in some of the other videos. Remember that you're starting with a curved blade. It's more forgiving of imperfect placement than a Miller blade, and you want stepwise progression when you intubate. So the first step is you insert the blade. You insert that without doing dental damage, so you're looking at the teeth, and you tongue sweep to the left, and you advance the blade. Now the first thing you're looking for after that sweeping of the tongue is the epiglottis. You're not looking for the vocal cords, and I'm going to show this to you in the video that comes next. You're looking for the epiglottis, and that tip of the blade needs to go at the base of the epiglottis. So what you're trying to do there is put the tip in the right position. Notice you haven't started lifting the laryngoscope yet. First thing you're doing is getting the tip to the base of the epiglottis. Once you've done that, then you lift up and away. If needed, you do a burp maneuver, which is backward, upward, rightward pressure, which I'm going to show you shortly. And that's the position that you need to be in. This diagram is taken from Airway Jedi. There's the reference. Go and read that. It's a very nice reading that you can look at about intubation. Keep your back straight. Don't rotate your wrist, and lift up and away in that direction. That rotation of the wrist is what we start doing when we are in trouble and we can't see. We're trying to see around the corner. And generally what you've got to do is position your laryngoscope blade better, not try and rotate it upwards. So the burp maneuver stands for backward, upward, rightward pressure. And this maneuver is really, really useful in converting an airway that looks like this when you go into the airway. So what you do is you see there, I haven't got a great view, so you ask your assistant to press down on the cricoid ring and then press it upwards towards the jaw and to the patient's right. And if you're holding a laryngoscope there, that will then bring the airway into view like this, and you'll see the vocal cords. I find this very, very useful. I often do the burp maneuver myself while my left hand is on the laryngoscope. I pull the larynx over to the right, and then I get the assistant to hold it where I want them to hold it. So this is a maneuver you should use every single time you haven't got a good view. So that's the burp maneuver, and then the next thing you do is you watch the tube go through the cords. It's a common problem you see the cords nicely, you bring in the tube, and then you obscure the view, and then you push and you think it's gone through, but you haven't actually seen it go through the cords. So if you're not watching it go through the cords, you need to adjust your technique. So what you need to do is identify the anatomy well. We obviously haven't got it well identified here. There are the cords and the glottis. So here is someone actually doing a laryngoscopy. They've putting the laryngoscope blade in, not doing a very effective tongue sweep, looking for the epiglottis. And there it comes, trying to get the tip of that blade at the base of the epiglottis, and that's called the vallecula. And that's where you want to do your laryngoscopy. Here, the person has it in a good position and then goes for gold and goes a little bit past it. Now, there are the cords, but that's not where you want the tip. So he comes back appropriately, puts it in the vallecula, and now has earned the right to lift the epiglottis. There you see the vocal cords and the glottis. So now we know where the tube's going to go. The tube is now coming in. You watch it go through the vocal cords, and then what we all do when we're doing it for the first time, we push it too far. So when we've got difficult airways or we're nervous, we stick tubes too deeply. So now you need to make sure you haven't pushed it too deeply. And there is the second line. That's one way of deciding on depth. And then we have the tube to the right depth. So that's basically laryngoscopy. The next thing we need to do is learn how to use the bougie. So when you're struggling, either to get the tube in or you don't see appropriately, one of the ways that you can intubate is to insert a bougie and then railroad the tube over. So now I'm going to show you a video of how that looks. As he's got his nice view, gets the assistant to hand him the bougie, that goes in, he's now intubated, feels it stop, the assistant loads the tube, he takes the tube, the assistant takes the top of the bougie and he pushes it in. Now they're going to show that to you again, a little bit slower. That's all quite rushed. Just watch, there's a special thing that he does here. As he's pushing that tube in, watch him rotate it anti-clockwise. And that's what helps it get over the arachnoid cartilages. He then takes the laryngoscope out and out comes the bougie. That's a technique worth learning. I want to show that again. Also to show you something else, watch as he's putting the bougie in. That left hand never comes off the laryngoscope. So the bougie goes in, the assistant loaded, the left hand hasn't moved. The right hand grabs the tube, pushes it and corkscrews it, and then the assistant will pull out the bougie. And just to show you that corkscrew maneuver again, grabs it, twists it anti-clockwise. That's going to help it just ramp over the arachnoid cartilages. Assistant removes the bougie and he's holding onto that tube. That's a lovely technique and one worth learning. Finally, as a rescue technique, if you haven't managed to get the endotracheal tube in, you need to know how to insert an LMA or a supraglottic airway device. Tips here to help is that you lubricate the back of that supraglottic airway device. Usually we don't have it fully inflated, but we also don't fully deflate it. We leave a little bit of air in the LMA, and then you can watch here the insertion technique. So you open the jaw a little bit, get it over the teeth. The first resistance you feel is the tongue. We often extend the neck a little bit and we push it against the tongue. You can see there's some resistance that he's encountering here, so he gives it a little bit more pressure and pushes it over the tongue and then feels it bite and sit correctly. Now, most of us will put that LMA in and we'll just push it directly backwards once we've got it over the tongue. The correct technique is actually to follow the curve of the hard palate into the soft palate. So it's a slightly concave direction that you're putting it slightly superiorly, and then as you get behind the tongue, you push it around and inferiorly, and you'll feel it sort of sit nicely at the back of the pharynx. You then inflate the LMA and you'll actually see it bob up a little bit if it's in the right place. So those are techniques that you need to practice. Just remember that when we're doing these airway techniques, it always starts with airway assessment. You always prepare for your primary technique and what you'll do if that fails, and that might be a supraglottic airway device or it might be the use of the bougie. We always position the patient correctly, best position the first time. We oxygenate well, and then we go ahead with the technique that we want. And that's all.